Hi everyone, my name's Lucia. I'm a current fourth year medical student. We're a few weeks away from the match, and I'm wanting to go into radiation oncology. Um, right now, I am on one of my radiation oncology rotations, and so I'm watching some brachytherapy. Um, so this kind of inspired me to start a series called Linux Logic. This is actually my first video, uh, and that's why I'm randomly starting on the female pelvis. But this is going to be an anatomy review, and then I'll have other series of videos talking about different cancers and how RTOG studies and etc. So yeah. So to get started, I wanted to talk about the anatomic structures of the female pelvis. So first things first, we're going to talk about the uterus. So here's the uterus. This is a thick-walled muscular organ, and it's located between the bladder, in the midline between the bladder and the rectum. You can't see the rectum here. And usually with a normal adult uterus, it's anaverted, which means that it's tip forward, and it's aniflexed, which means that it's curved and flexed anteriorly. So before we get into the anatomical structure of the uterus, I wanted to talk about some functions. So first and foremost, the uterus plays a big role in menstruation. So when there's no pregnancy, the inner lining of the uterus, or the endometrium, starts to shed, and that's what leads to menstruation. The uterus also plays a role in fertilization and implantation. It provides an environment for the fertilized egg, after being fertilized, to plant and develop, and pregnancy support as well. The uterus actually houses and supports the developing fetus. So when the fetus grows, the uterus expands. Labor and delivery, during childbirth, the uterus is what contracts to actually give birth. And then hormone production as well. As for the regions of the uterus, this is the uterus right here. So we'll start from the top. Let me get my pointer. So this is the fundus of the uterus. So that's that dome-shaped portion of the uterus, and it's above the opening of the fallopian tubes, or the uterine tubes. So right here, and it's above, and it's located above the uterotubal junction. Then we have the body of the uterus, or the corpus, which in Italian and in Spanish, like corpo, which means body. So that is the upper 2/3 of the uterus, and this is the body of the uterus is important, especially because that's where the implantation of the embryo typically occurs. Then we have the isthmus, that I'll show you better on another image, but that's that narrow portion between the body of the uterus and the cervix, and it's located just above the cervix. And then we have the cervix right here. And that's the lower narrow part of the uterus that connects to the vagina, or the inferior 1/3 of the uterus. So let's talk about some of the layers of the uterus. So this is a really good image right here. So we have 3 layers. So we have the perimetrium, the myometrium, and the endometrium. So the perimetrium is the outermost layer of the uterus. It's the serous layer, and it helps with smooth movement of the uterus within the pelvic cavity. So that's the outside. Then the myometrium is the middle, so myometrium middle, and that's made of smooth muscle, and this is what actually contracts during labor and delivery and childbirth. And then the endometrium is what we discussed before, so that's the innermost lining. It's a mucosal lining of the uterus. And during the menstrual cycle, this is the layer that thickens for a potential implantation of a fertilized egg. And if that implantation does not happen and pregnancy does not occur, then this is the layer that's going to be shedding, and that's what leads to menstruation. So I just wanted to include this here. This is a little more in depth. So we talked about some of these structures, and some we haven't seen yet. Um, but this is the cavity of the uterus. So this is where there would be implantation. This is the uterine ostium, so that's at the uterotubal junction. We have the internal os at the uterine isthmus that we were talking about before, so that's right there. And then the external os of the cervix, and all of this we're going to go more in depth. Then we have the cervical canal right here, and the fornices and all of that, but we'll go more in depth with this. I just wanted to show this image so it's not as overwhelming. So now we're going to switch gears just a little bit and talk about the uterine tubes, or how I know them as the fallopian tubes. So functions of the fallopian tubes are for egg transportation. So here's a fallopian tube, and this is the body of the uterus. Here's an ovary. And so what it means by egg transportation is that when an ovary releases an egg, the fallopian tubes have fimbriae, which are these kind of like, they're going to sweep the egg into the fallopian tube, and it's going to go all the way down and then implant in the actual uterus. So yeah, function number 1, egg transportation. Function number 2 is fertilization, which occurs in the ampulla, and I'll show you where the ampulla is in a second. And then it also supports early embryonic development, and that's kind of what this image is. So the fallopian tubes are where, after fertilization, the zygote or the fertilized egg undergoes cell division. So you can see all the cell divisions here. And that's going to occur until it implants in the uterine body. And then the fallopian tubes also have ciliary action, and that's kind of what's going on here and around here. What's actually helping, it's like a conveyor belt almost, and it helps move the egg to implantation in the uterine cavity. So now I wanted to talk about the regions of the fallopian tube. So I'm looking at this image right here for starters. This is kind of like a bare bone, color coordinated image. So just to orient ourselves, this is the uterus, and this is going to be the fallopian tube, and this is an ovary. So first off, we're going to talk about the infundibulum, and just like it's described, it's this funnel-shaped end that's closest to the ovary, with these finger-like projections called fimbriae. So that's the fimbriae in blue, and that's what actually captures the egg that's released during ovulation, and it's going to move the egg through here and have all those divisions happen, and then implantation. I remember fimbriae like that little, if you ever go to like a car wash and there's that like guy that's like the blow up thing that is kind of moving everywhere, that's kind of what I think of fimbriae. Then we have the ampulla, which is right here. I think of the ampulla like the armpit. So ampulla, that's where fertilization actually occurs. And that's the space between the infundibulum, so that funnel shaped, and the isthmus. The isthmus is what actually connects the ampulla to the uterine body. And then we have the intramural segment, which I will show you better on the next slide, but this is the intramural segment right here, so it's after the isthmus. And that's the segment that passes through the uterine wall and opens into the actual uterine cavity. I just wanted to include this slide here because unfortunately ectopic pregnancies do happen. So as we talked about before, pregnancies usually occur within the uterine cavity. So an ectopic pregnancy is going to be a pregnancy that occurs outside of the uterine cavity. And so this image is showing kind of all the percentages of cases that where ectopic pregnancies can happen. The one that's going to be the most common location for ectopic pregnancies are going to be in the ampulla, and we can see here it's about 70%. So I just wanted to include this here because we're going to see this image a lot. It has a lot of things labeled. So let's kind of do a little quick review. So we have the fundus, that's that dome-like shape. We have the body of the uterus right here. We have the cervix, and then the vagina. And then talking about the fallopian tubes or uterine tubes, we'll start off here because this is how the physiological process actually happens. So we have the ovary. It's going to release an egg, and these are the fimbriae. That's that little car wash guy, and it's like, come here, egg. And so it goes from the fimbriae, or kind of like the little arms of the infundibulum, into this funnel-shaped infundibulum. It's going to go up into the armpit of the ampulla, and then through the isthmus and into the intramural segment, and then into the uterus to be implanted. And then here we have the endometrium. So we talked about kind of when there is no pregnancy, that's what's going to shed, right? And that's what's going to lead to menstruation. We have the myometrium over here. So if there was going to be a pregnancy, that's what's going to help us contract to actually give birth. So we kind of went through all of that. And then I feel like this side, here's a really good picture of the fimbriae. And then this side, all of these labeled things we will go into in a second, but I just wanted to take some time and kind of go over that. Okay, now we're going to move on to the lower portion of the uterus, which is the cervix. So the cervix connects the intrauterine cavity to the vagina. So intrauterine cavity, down here is the vagina, and this is going to be the cervix. We have what's called the external os of the cervix, which is the quote-unquote mouth of the cervix. When women go, or females go to the gynecologist and they get a speculum exam done, whether it's a pap smear or just looking, this is what is visible on exams. So right when you open the speculum, you're going to see the external os. And then we have what's called the cervical canal, or the endocervical canal, and that's the space, the passageway through the cervix, and it starts at the external os and ends at the internal os, and it's what's labeled here in blue. And it's formed by the internal narrowing of the uterine isthmus. Okay, so this is a very important slide. This is talking still about the cervix, but we are going to talk a little bit about what's called the transformation zone. Before we get into that, this is like, if I could put a star next to this, this is super important. So the endocervix, which is the innermost part, the innermost layer of the cervix, is covered in columnar epithelium. So we can see here we have the endocervix, and this is going to be kind of the columnar epithelium. And then we have the ectocervix, which is the outer layer of the cervix, and that's going to be covered in stratified squamous epithelium. So that's what this is. So the transformation zone, it's in red, it's super important, is the zone, it's located between the external os and the internal os of the cervix. So kind of in that endocervical canal. This transformation zone is where the columnar epithelium of the endocervix, so the inside most layer, the columnar epithelium, that's when it transitions into the stratified columnar epithelium of the ectocervix, or the outside. So that's what's happening right here. So we have the inside of the cervix, the endocervix, it has columnar epithelium, and then it's going to transition right here into what the ectocervix is covered in, which is stratified columnar epithelium. This area is known as the squamocolumnar junction, and that's what's labeled right here. And this is the site the most common site for carcinogenesis, so cervical cancer. I got that a lot on test questions, so wanted to mention. Lastly, we're going to talk about the vagina. So this is the vagina right here. So the vagina is a fibromuscular or elastic tube. It's usually 8 to 10 centimeters long, but it can expand during childbirth. And it's mostly made up of smooth muscle and mucus lining. Yeah. I just wanted to make a quick note about vaginal fornices. So there are a couple of fornixes that we need to know. So basically, this is a speculum, and when you do the speculum exam, you can see a couple of these. So this is kind of a more detailed image of what we're seeing here. So the anterior vaginal fornix is right here. It's located in front of the cervix and near the bladder. Then we have the posterior fornix, which is over here. So this would be the anterior. If you're using a speculum, here's the cervix, so the anterior would be closest to the bladder. And there's the bladder. And then the posterior would be closest to the rectum, and we see the rectum over here. So this is the posterior. And then we'd have two lateral fornices on the right and the left. And you can see those on speculum exam as well. So I just wanted to, this is a very clinically relevant and also a test question. So what structures can actually be palpated on by manual exam? So usually when someone goes to the gynecologist or OB-GYN, they'll do two things, usually a speculum exam, and then they have the bimanual exam. So that's, here are the stirrups. And so things that you can actually palpate on bimanual exam are going to be the cervix, so right here. And then you can actually do kind of a sweeping motion to feel the ovaries. So the ovaries right over here. And the importance of that is because you can actually feel for any abnormalities such as tumors or cysts. And then you can actually palpate the ischial spines as well as the uterine artery pulsation. Moving along, I wanted to talk a little bit about the ovaries. So the function of the ovaries, number one, is going to be oogenesis, which is the actual production of oocytes, which are eggs. So again, even though we talked about the uterus first, the actual process is starting from the ovary and then going like this into the uterus for implantation. So oogenesis, this process actually starts before birth, and then each month during the reproductive years, one mature egg is ovulated and released from the ovary. And then if it meets a sperm, there's fertilization, and if it doesn't, then there's menstruation. Then we have hormone productions like estrogen, progesterone, and a really small amount of testosterone. Ovulation, which is that process of releasing the mature egg from a dominant follicle in the ovary. Ovulation usually occurs during the middle of the menstrual cycle. And then we have support for pregnancy. So if fertilization does occur, we have the corpus luteum that secretes progesterone, and that maintains the uterine lining for pregnancy. And if pregnancy doesn't occur, then the corpus luteum degenerates, and that leads to a drop in hormone levels and actually leads to the onset of menstruation. The ovaries are suspended by 3 ligaments. So I will go very much in detail of this, but I just want to kind of get an overview here. So the first one that we're going to talk about, I'm actually going to go from probably the easiest to the most difficult, just because this is the first time we're going over this. So ovaries are suspended by the ovarian ligament, or the ligament of the ovary. So here's the uterus, here's the ovary, and then we have this ligament of the ovary connecting the two. Then we have the suspensory ligament of the ovary, which it sounds just like what it's doing. It's suspending the ovary kind of in the air almost. So here's the suspensory ligament of the ovary. Here's the ovary, and this is also called the infundibulopelvic or IP ligament. You're going to hear me refer to it as the suspensory ligament of the ovary. And then lastly, we have the mesovirium, which is, if we can follow this arrow up, it's going to be right here. And that is what, when we talk about the broad ligament, and we see it labeled here, there's 3 parts to the broad ligament, and that's just one of the 3 parts, and we'll get more into it in a second. So just wanted to review again, now that we started talking a little bit about this. So ligaments are very, very important. So first one that we're going to kind of see more of is the suspensory ligament of the ovary, or the infundibulopelvic ligament, or the IP ligament, but I'm going to call it the suspensory ligament of the ovary. It's kind of like suspending the ovary in air. Not really, but just to remember it. The ligament of the ovary is right here. That's probably the easiest one to remember. And then we have the mesovirium, which is one of the 3 parts of the broad ligament of the uterus. And so mesovirium is right here. So now we're going to go pretty in depth on each of these ligaments and what vessels they may or may not contain and all the rest. So here we go. So first I want to talk about the broad ligament. So here's the broad ligament, and it's kind of in green. So we said the broad ligament has 3 parts, and it's this sheet-like fold of peritoneum. It's a double layer of peritoneum. And so the superior margin encloses the fallopian tubes. So we see here the fallopian tube, and it's covered in green. And then the posterior margin suspends the ovary. And then the uterine artery actually travels inferior to the broad ligament. So yeah, we'll go over this many, many times. So as we said before, there are 3 parts of the broad ligament. So we have the mesometrium, the mesosalpinx, and then the mesovirium. So we already talked about the mesovirium. That's the posterior extension, and it's what attaches. It's one of the ligaments that attaches the ovary. Can you remember the other 2? It was the suspensory ligament and the ligament of the ovary, and then we have the mesovirium. And then we have the mesosalpinx. That's the most superior portion. So that was that green part that was suspending the fallopian tubes. And I'll show you another picture of this. And then the mesometrium. And that's the largest part of the broad ligament, and that extends from the lateral pelvic wall to the body of the uterus. And I think these are best seen with images, so we'll go over this. Okay, so this is probably the best image that is out there for actually seeing what these ligaments look like. So the broad ligament, we said, has 3 parts. So we have the mesometrium, that's kind of like the largest portion of it. It's kind of like this blanket that's draped over. We have the mesosalpinx. So I actually spelled mesosalpinx incorrectly on the previous side. It's with an E, not an A. I will change that. But that is what covers the fallopian tube. So that's another part of the broad ligament. And then lastly, we said the mesovirium, and that was what was holding the ovary in place. So here is the ligament of the ovary, and then over here was the mesovirium that was suspending the ovary. Just to really hone this in one more time. So here is the three parts of the broad ligament. We have the mesometrium, the salpinx, and the mesovarium. So mesometrium is kind of like the largest part of the broad ligament. It's this yellow part right here. Then we have the mesosalpinx, and that's what's actually covering this fallopian tube. And then we have the mesovarium, which is what is suspending the ovary. And this is kind of that little portion of the mesovarium that we see. So now I feel like this image is a little less overwhelming. I feel like we talked a lot about this. So I would just stop here and just kind of talk to yourself about this, kind of review it by yourself and see if you can kind of reason through what all of these parts of the uterus, fallopian tubes, and ovaries, and all the ligaments are. So we're going to keep going with ligaments. So the next that we're going to talk about is the round ligament. So the round ligament actually attaches near the uterotubal junction, and I'll show you a way better picture than this one. But this image is really important because it actually shows you the full kind of course of the round ligament of the uterus. So it courses upward and then laterally, and then it actually goes through a deep inguinal ring, which is right here, as well as a superficial inguinal ring. And then the round ligament of the uterus, the fibers actually terminate in the mons pubis and anterior labia majora, which this picture you can't really see really well here, but at least getting an idea. This is kind of like the pubic symphysis, and then this is the glans clitoris, so somewhere over here. And the round ligament is analogous to the spermatic cord in males. So I wanted to include this image because I feel like it shows a little better kind of where this round ligament of the uterus is going. So it's kind of going up and then laterally, and then it goes into a deep and superficial ring, and then it's going to actually terminate near the mons pubis and near the anterior labia majora. Next, we're going to talk about the transverse cervical ligament, or the cardinal ligament. So I'm going to call it the cardinal ligament. So cardinal ligament helps anchor the cervix to the lateral pelvic wall. You can remember that because cardinal ligament starts with a C. So cardinal ligament is going to anchor the cervix, which also starts to the C, to the lateral pelvic wall. And I did not take credit for that. That is from Radong Talks. So thank you for that. And then the important thing about the cardinal ligament is that the uterus and the uterine arteries actually course through this ligament. So that is super important. So uterus and the uterine arteries actually course through the cardinal ligament. And so now I'm going to show you kind of where it is here. This is also a very busy image, but by the end, hopefully this will look pretty familiar. So cardinal ligament is right here. So again, we're kind of connecting or anchoring the cervix to the lateral pelvic wall. Just kind of as a foreshadowing, we're going to talk about the uterosacral ligament, and that's just right here. And then once again, we have the round ligament of the uterus. So again, going up and laterally, and then through the deep inguinal ring, and then the superficial inguinal ring, and then out to the mons pubis and the anterior labia majora. And I think that's pretty much, here we have the ligament of the ovary, but the ovaries are cut off, so it's there's better images, so I think that's all I wanted to review here. Okay, so now we're going to talk about the uterosacral ligament, and as the name sounds, again, this is connecting not connecting, but anchoring. This is kind of like a safety belt, honestly. This is what I think about when I think of the uterosacral ligaments, and even the cardinal ligament, I think of like a seatbelt. So this is anchoring the uterus to the sacrum, And you can see it right here. It's literally like kind of forming a circle around it. And this ligament is actually palpable during a rectal exam. And then we've kind of already touched on this, but again, the suspensory ligament of the ovary over here. So it's not actually suspending the ovary in air, but just to kind of remember it that way. It's also, again, called the infundibulo pelvic ligament. The really important part of this is that it actually contains the ovarian vessels. And when we talk about vessels, we mean the artery and the vein. And you can actually see this, the ovarian blood vessels over here, and it's encased in the suspensory ligament of the ovary. And then once again, this is the ligament of the ovary over here. So now we're going to talk about the ligament of the ovary. I would not call it the ovarian ligament just because anatomically correct. It is the ligament of the ovary, so my apologies. But this provides support and anchors the ovary to the uterus. And when patients have to go through an oophorectomy, which is literally the surgical removal of the ovary, the ligament of the ovary is ligated and severed. Also, another correlation is that this is the ligament that actually, when the ovary undergoes ovarian torsion, there's actually twisting around this ligament of the ovary, and it cuts off its blood supply, and it's actually a medical emergency. And then I just wanted to include this here because I feel like this is also many test questions. So kind of what needs to be cut, identified, and severed during a hysterectomy. So during a total hysterectomy, the first things that you're going to do is identify the round ligaments of the uterus, the cardinal ligaments, and the uterosacral. Because again, those are kind of like all the seatbelts of the uterus. So you're going to identify all three of those ligaments and actually cut them. Then you want to identify and actually cut the ovarian ligament, or the ligaments of the ovary, and then you want to identify and cut the uterine vessels. And so the uterine vessels are over here, the uterine vein, and the uterine artery. What you don't want to do is, if you can look right here, that's the ureter. And so you do not want to cut the bilateral ureters. You actually want to dissect them out, and isolate them and make sure that they're spared. And then I just wanted to include a slide about retroperitoneal reflections. So this is a pretty good image of two of the famous pouches. So one of them is the vesicular uterine pouch, also known as Dunn's pouch, and that's located between the bladder and the uterus. So this is just a cartoon bladder, uterus, pouch in between. The importance of this is that there can be a lot of fluid accumulation, so a lot of infections, a lot of inflammation that actually accumulates there. And so that is an area where you can actually like take some fluid and test it. And then surgeries like hysterectomies or C-sections have to go by this vesicular uterine pouch. And then we have the rectouterine pouch, also known famously as the pouch of Douglas, and that's between the rectum and the uterus. So, sorry, it's right here, and then the uterus is over here. And again, fluid accumulates around there as well, and a lot of ectopic pregnancies or peritonitis you can kind of test for by taking some fluid from there. So this is an ultrasound, very important and really good image actually. So here we have the uterus, we have the ovary, we have the ovarian ligament right here, and then we have the round ligament. And then again we have the suspensory or IP infundibulopelvic ligament here. or the suspensory ligament. Okay, so we are, this is just another kind of review slide. So we have this blanket of a broad ligament over here. But what I really wanted to include this in for was the suspensory ligament. So once again, that's what holds the ovarian vessels or the ovarian artery and the ovarian vein. This is the ureter. Again, we do not want to cut that during hysterectomy, but we do want to cut the uterine arteries. And then I think that was pretty much all I wanted to mention here. And then you can just kind of see this uterosacral ligament over here as well. So now things are going to get a little bit more complicated, but I did want to talk about some blood supply of the female pelvis, so please bear with me for this part. And the next is going to be nerves, so these are probably the two hardest parts. Okay, so blood supply to the vagina, we're just going to start there. Is mostly the main blood supply is going to be the anterior division of the internal iliac artery. And we will go into the anterior and posterior divisions of the internal iliac artery another time, but for right now, this is just what we're going to mention. So the superior portion of the vagina is actually supplied by the uterine artery. And again, the uterine artery, the origin is the anterior division of the internal iliac artery. Then we have the middle vagina is supplied by the vaginal artery. And again, that is from the anterior division. And then the inferior vagina is supplied by the internal pudendal artery. And I know that the pudendal, there's a pudendal artery nerve, but that is actually still from the anterior division of the internal iliac artery. This is a really important slide and very confusing, so I would just take some time with this. Okay, so now just to recap, so we kind of talked about the superior aspect of the uterus is supplied by the uterine artery, so we have it over here, and that is from the internal iliac artery. So we see here the anterior division of the internal iliac artery is going to supply the superior portion of the vagina. Then we have the middle vagina that is supplied by the vaginal artery. The vaginal artery, again, is from the anterior division of the internal iliac artery. And then lastly, we have the inferior portion of the vagina that is supplied by the internal pudendal artery. And that is from the anterior division of the internal iliac artery. So this is a nice image too. So we talked about the blood supply to the vagina, and now we're going to talk about the blood supply to the uterus. So the main blood supply to the uterus is from the uterine artery, which is from the anterior division of the internal iliac artery. So this is a really good kind of, just like the isthmus and the fimbriae image. I really like this image just because I'm color coded. Just helps a lot. So here's the uterus and then the uterine artery, and it's coming off the internal iliac artery. And just a little note that in a uterine artery occlusion, so let's say we don't have this, there's going to be collateral circulation to the uterus that's supplied from the ovarian arteries. And we can see that here. The blood supply to the ovaries are a little special. There's actually two blood supplies to the ovary. One of them is going to be the ovarian artery. So that's pretty easy to remember. The only thing that you have to also remember is that this artery is not from the anterior division of the internal iliac artery. It's actually from the abdominal aorta. And you can see that nicely drawn here. So this is the aorta, abdominal aorta, and then we're going to give off the ovarian artery. And that artery, if you follow it, is actually going to go into the suspensory ligament and actually supply the ovary. That kind of branching off happens just below the renal arteries at around the level of L2 vertebrae. And then, as we talked about, the ovaries can also be supplied by the uterine artery, which is from the anterior portion of the internal iliac artery. And it gives off kind of these small branches. So if we follow it, the uterine artery here, it's going to kind of give off these really, really tiny small branches, particularly around the ovarian ligament and the fallopian tubes. And as we said before, it kind of forms this anastomosis with the ovarian artery. And then lastly, I just wanted to kind of include this because a lot of people in anatomy talk about this all the time. It's kind of like a mnemonic, and it's called water under the bloody bridge. And so what does that actually mean? So this mnemonic is to help remember the relationship between the uterine arteries and the ureter in relation to the cardinal ligament. So we said that the cardinal ligament contains the ureters. And so here's where it's written. So the ureters are located within the cardinal ligament. The ureters are, we're going to say for this mnemonic is the water, and it lies under the bloody bridge, which is what we're referring to as the uterine arteries. So this is a really good image right here, because the whole point is that when you're dissecting or if you're doing surgery, you do not want to cut the ureter, but you might want to cut the uterine artery. So you're going to sever the uterine artery, but you have to be careful because water is under the bloody bridge, so it's pretty close. So you can see ureter here and then uterine artery here. Now I'm just going to move directions into venous drainage. I just wanted to keep artery and vein separate. Okay, so venous drainage of the vagina. The vagina is actually drained by the vaginal venous plexus. So here is a kind of 3D model of the vaginal venous plexus. So venous drainage of the uterus. So we talked about the vagina, now we're going to talk about the uterus. So uterus is drained by the uterine venous plexus. Sorry, this is not drainage, this is plexus. So this is the uterine venous plexus right here. And so actually the vaginal venous plexus and the uterine venous plexus actually communicate. So together they are collectively called the uterovaginal venous plexus. Wrong. Okay, so we're going to talk a little bit about the pathway of venous drainage. So as we talked about before, we have the uterine venous plexus and the vaginal together, kind of collectively called the uterovaginal venous plexus. So drainage pathway is going to be from these two plexuses or plexi, I don't think that's right, to the uterine vein. So this is a really bad drawing that I did. To the uterine vein and then into the internal iliac vein. I wanted to include the venous drainage of the ovarian vein or of the ovaries. So this is similar to males, but the right ovarian vein, which is going to be right here, it got cut out a little bit, is going to drain directly into the IVC. And then the left ovarian vein, which is over here, is first going to drain into the left renal vein, and then it's going to drain into the IVC. So this is probably the hardest part of this, so please bear with me. I am by no means an expert in this, so I will try my absolute best. Okay, so this is just an overall introduction of the nerve plexus in the pelvis. So I tried to get the best image that I can find for this because it's very, very confusing. So this is just an overview. So the first thing we're going to talk about is the superior hypogastric plexus, which you can see right here. So this makes up mostly made up of the sympathetic nerves from the lower back, so T10 to L2. These nerves are what supply the pelvic organs, and then it's going to split into the hypogastric nerves that are not labeled here. There's an inferior one here, but we're going to get into that. So, superior hypogastric plexus is going to split into the hypogastric nerves that are not labeled here. The hypogastric nerves are what carry the sympathetic fibers and travel down the pelvis. They join together and form the inferior hypogastric plexus. So this thing is going to superior hypogastric plexus. It's going to split into two into the hypogastric nerves, and then it's going to come together again and form the inferior hypogastric plexus. The inferior hypogastric plexus holds both the sympathetic and the parasympathetic fibers. The sympathetic fibers that it is holding are from the hypogastric and the sacral nerves. I'm going to say that one more time. So the sympathetic fibers that the inferior hypogastric plexus contains are from the hypogastric and the sacral nerves. The parasympathetic fibers from that are located in the inferior hypogastric plexus are from the pelvic splanchnic nerves, S2 to S4. Then these fibers basically come together and travel to various organs and tissues in the pelvic area. So that is an overall just introduction. This is a better image. So we have the superior hypogastric plexus, and it is going to split off into the right hypogastric nerve, and there's going to be a left. And then from that, it's going to come together and form the inferior hypogastric plexus. So that is what I wanted to show. So this is the nerve supply to the vagina, uterus, and adnexa. So the sympathetic nerves are going to start in the low back around the lower thoracic spine. The sympathetic nerves are going to travel through the superior hypogastric plexus. They're going to split off into the hypogastric nerves and then come back together into the inferior hypogastric plexus. The sacral splanchnic nerves also contribute to the sympathetic innervation. This is once again the nerve supply to the vagina, uterus, and adnexa. So the parasympathetics, they travel through the pelvic splanchnic nerves and the inferior hypogastric plexus before actually reaching the uterovaginal nerve plexus. So once again, we have the superior hypogastric plexus. It's going to break up into the hypogastric nerve, right, left, and then it's going to come together and form this inferior hypogastric plexus. The parasympathetics are going to get innervation from the pelvic splanchnic nerves at S2 to S4. And you can actually see it here, S2 to S4. Now we're going to talk about, we're still on vagina, uterus, and adnexa, but now we're going to talk about somatic innervation and what is the difference between somatic and visceral. So we'll start with somatic. Somatic innervation is voluntary and sensory. So what is the somatic innervation of the vagina, uterus, and adnexa? The deep perineal nerve, which is a branch of the pudendal nerve. So we see the pudendal nerve here, but I don't think we see the deep perineal nerve. But that is what's going to supply sensory innervation, especially for touch and temperature, to the lower 1/4 of the vagina. So again, we were talking about somatic, that was looking at voluntary and sensory information, and then now we have visceral innervation, which is involuntary or automatic or autonomic innervation. So visceral innervation of the upper vagina and uterus comes from the uterovaginal nerve plexus, which follows the uterine artery. But visceral innervation comes from the uterovaginal nerve plexus. The uterovaginal nerve plexus is an extension of the inferior hypogastric plexus. So again, we have the superior hypogastric plexus, then we had the hypogastric nerves, and then inferior. The inferior, the uterovaginal nerve plexus is an extension of the inferior hypogastric plexus, and it contains the sympathetic or GVEs, which contain the motor signals, and it contains the sensory GVAs. This is efferent and afferent. So efferent is going to take the motor signals, and then afferent is going to be the sensory signals. I think we are reaching the tipping point of one of the hardest things to understand. So this is the pelvic pain line. So what is that? And that is a threshold of determining the course of visceral pain sensation in the pelvis. So if an organ is above the pelvic pain line, so first of all, organs that are intraperitoneal structures are considered being above the pelvic pain line. And those structures, their pain signals travel with sympathetic nerves to T10 to L2 spinal area. Structures that are subperitoneal structures are considered to be below the pelvic pain line, and those pain signals travel with parasympathetic nerves to the pelvic splanchnic nerves, which is S2 to S4. So again, this is the pelvic pain line. So anything that's intraperitoneal is going to be considered above, and then anything that's in subperitoneal structures is going to be considered below the pelvic pain line. And they're going to have different, so above is going to be sympathetics, below is going to be parasympathetics. Lastly, or almost close to being done, but the nerve supply to the ovaries and the fallopian tubes. So the ovaries actually have their own ovarian plexus, and there's also a testicular plexus, but here we're going to talk about ovaries. And the ovarian plexus, basically the nerve supply is derived from the ovarian plexus and the uterine plexus for the ovaries and the fallopian tube. I just wanted to talk about parasympathetics to the ovaries because it's actually pretty interesting. So because the ovaries have a embryological origin from in the abdomen, their parasympathetics actually come from the vagus nerve instead of the pelvic splanchnic nerve, which I thought was pretty interesting. And then the ovaries, the sympathetics to the ovaries are from T10 to T11 by the lesser thoracic splanchnic nerves, and they course through the ovarian plexus. And then this is actually the last slide, but the visceral innervation, so that visceral pain sensation of the ovaries and the fallopian tubes, because the ovaries and the fallopian tubes are considered intraperitoneal structures, they are considered to be above the pelvic pain line. So the pain signals travel with sympathetic nerves to the areas of T10 to L2 spinal area.